Hello everyone. We are going to talk about antihypertensive medications today. First, a little introduction, and I'm trying to figure out how to do this the best way, but we're going to talk about some things that you may be hearing about in ICM as far as the management of the patient goes. So I'm not trying to step on any toes. I know we're supposed to keep things separated, but it's just here just for a complete picture, just some, and also you can kind of get the pharmacist perspective on some of this stuff. So, please refer to the ICM material that they provide when studying for that exam, etc. And then for my exam, I won't be pulling heavy test questions from management. However, I will be pulling test questions from some things that, some of the characteristics that make the drugs, a better choice in certain populations, which we'll get into here in a second. So, like for example, if someone has asthma, there's certain medications that are maybe not the best first line choice for those. So let's get into it. I think that'll make more sense once we start talking and kind of give you some examples and stuff. But so antihypertensive, what does this word mean? Let's chop it up real quick. Anti means against, hyper means over, and tensive or tension means pressure. So this is your anti-hypertension, which is high blood pressure in layman's terms. So these drugs will help lower blood pressure, right? Simplest terms. Definitions, again, just kind of background stuff. Don't stress about memorizing this stuff. This is kind of historical fun facts. I do want you guys to be familiar with and know what the JNC is. So this is the Joint National Committee, and you can read the whole full title there. So you'll hear people talk about JNC when you're on rotations, and so this is part of the reason I'm making sure everyone's on the same page as far as their background, because you guys all have different healthcare backgrounds and everything. First one way back in 1976. So those are the first time they got together. So this is a board or a group of experts, physicians, PhDs, etc., just researchers and practitioners. And again, so this is something I would encourage you guys to be using when you're new practitioners. Use the JNC. They're up to JNC 8 right now, so number 8 is the most current one. Definitely look at those and use those. Speaking of, let me go ahead and jump out of here real quick. So I wanted to show you, with that, just Google search JNC hypertension guidelines or something along that. 8's the most recent one. I like this. This is PDF here. If you click on it, it opens up here. Let's see what it looks like. So this is the JNC hypertension guideline algorithm. I like algorithms. Again, some critics say this is cookbook medicine. I definitely like these. I think, again, for new practitioners, these are good things to look at. But this is a nice, and so there's a whole bunch of these different algorithms out there. Whatever one you like better. I like the way this one looked, and it's colorful, etc., whatever. But it basically tells you how to kind of go through. So general population, do they have diabetes or not? Yes or no. Are they non-black? Are they black? Yes or no. What's their goal, etc. Stage, and then initial choice of hypertension, I think is good. Lifestyle changes, which is good. We'll talk about a little bit. It tells you what to do, how to measure it, etc. This is what I was talking about earlier, so definitely pay attention to this. It will be in my slides and it is elsewhere, but so there's sometimes what they call compelling indications. So there's a reason that an ACE inhibitor, for example, ACEI, I'm sorry, that's an abbreviation, may be beneficial in recurrent stroke prevention, for example. So I want you guys to know those. Pregnancy too, you'll notice that. Something to look at there. Has a note about beta blockers may be safer in certain patient populations, like I mentioned. Wanting you guys to highlight that and look at that. I also like this table here for studying purposes. I think this might help you guys. It has a drug class, which I want you guys to know, of course, classification, right? Agents of choice. So of that class, which ones are preferred? So because with not all diuretics are created equal. Not all vasodilators are created equal. So there's a lot of different vasodilators. Maybe they're not all appropriate for hypertension. So look at those there. And then comments. So this is good things as far as just adverse effects. Calcium channel blockers, edema. That's a good one to know about. ACE inhibitors, cough, angioedema. Hyperkalemia. Sorry, we'll get on to this in the slides. I'm seeing some good stuff on here, getting excited for you all. But this is a 2-page PDF from, again, JNC 8, most current guidelines that I'd recommend you guys check out. And I think it would help you guys study for my course. And then I think it also helped for ICM. So let's go back to the slides. And by the way, too, if like with anything, if you can't find that PDF, just email me and I can get you the PDF directly if you're having trouble downloading it or whatever. And then also on that same note, if you find another PDF or you find some other source, so Up to Date I know has some algorithms, they have some different tables and stuff. Really, whatever you guys like is, as long as it's current and it's from a reputable source. More definitions here. Just go ahead and read through this. But this is important because of, again, textbook definition for hypertension. It's not just someone, saying that they have hypertension or not. So I mentioned JNC 8 is the most recent, but JNC 7 has the most current definition. So they did not change the definitions for hypertension in this latest edition. So you don't have to worry about, it's not out of date, basically, is what I'm saying with JNC 7. And then notice too, it's for 2 or more office visits after an initial screening. Up to Date has a couple tables that I like. This one is guidelines for the measurement of blood pressure to diagnose and treat hypertension. This is more maybe beneficial for your lab where you guys are doing the patient eval lab. And so this is FYI for my course, but I just thought it had some good stuff on there. I wanted you guys to just read through that. Here's another one too, approach to diagnosis of hypertension in adults, again from Up to Date, so feel free to look for that. I know there's a ton going on here. FYI for my course, I won't be pulling test questions from here. I just think just want to make sure you guys were aware of this. And part of the reason I do that is because in the past there have been students that like the resources that I use, or they have asked myself, oh, what do you look at? And so I'm trying to be proactive this year and give you some things that I think are beneficial, but by all means, delete it, erase it. I don't, you're going to hurt my feelings if you don't like the stuff I like. Classification of blood pressure, again, FYI for my course, but definitely look at it, know the definitions. For ICM, it's going to be important. But again, these are as of JNC 7, but they have not changed with JNC 8. So I would go through those. And then hypo means under or less. So the hypotensive is where someone has their blood pressure is too low, which can also be problematic, right? So to have the blood pressure too high or too low can be problematic and cause issues, both acutely and chronically, right? So just FYI for my... another one too, this is just FYI, but it's interesting. So anyone that is actively taking a prescription for an antihypertensive medication is considered to have hypertension. So that's just, don't stress out. A new practitioner, you can come across someone and they have, they're on an antihypertensive drug, an ACE inhibitor, let's say. Don't worry about then having to go back here and doing all this diagnostic stuff again. The guidelines, they recognize that if a person's prescribed and they're taking it, then they have hypertension. And just read through this again, FYI. This is just showing that JNC 8 basically agreed with previous definitions. Treatment rationale. So why are we interested in reducing hypertension? Because of long-term chronic damage, right? So read through all these. And again, you'll be getting this in ICM, but I just thought it'd be nice to put all that. And long-term goal, hopefully, reduce morbidity and death. Morbidity and mortality. You hear that a lot. The 2 M's. M&M. It's like the candy, but it's horrible. No. Morbidity and mortality. You hear about that a lot. But so we're trying to decrease that with these pharmaceutical agents, right? But before we get to the drugs, first-line treatment, TLCs, therapeutic lifestyle changes, or therapeutic lifestyle modifications, or dietary and lifestyle changes. There's a lot of different AKAs, there's a lot of different ways to say it, but basically first line, and we'll talk about this too with cholesterol, first line treatment recommended by the guidelines, all the experts, is that you should first try to not prescribe drugs. And I know it's very difficult. It's very difficult for people are really picky about what they eat, or it's food sacred to a lot of people, I guess is a good way to say it. So they get, and I've had this in the pharmacy, they get upset even when it's like, hey, this drug you're not supposed to have with this, they're like, hey, you can't tell me what I can eat, you can't tell me what to do. And it's like, well, okay, you can drink alcohol and take this medication and have a bad adverse effect, or drug interaction or whatever. But so people get very it's just hard for people to change their food and exercise, etc. So one thing that I came across, so I worked in a lipid clinic as a for the Chickasaws as a clinical pharmacist, and so we did a lot of lifestyle modification speeches to patients, or education. And one of the things I kind of landed on, a couple things that I like that I always like to try to share with students. One is the kind of most simplest, kind of most focused recommendation is eat less, move more, stop smoking tobacco. So most people will respond positive to that. So I'm not necessarily telling you, hey, don't have a hamburger. I'm just saying eat less of the hamburger. So also with lower socioeconomic patients that I've encountered, they'll say, well, I can only afford the 99-cent menu at a fast food restaurant. So, and I can't afford anything healthy, which, be empathetic, encourage them to eat other options and stuff. But if they're saying this is the only thing they can eat, well, then maybe propose that they eat half the hamburger and give the other half to a friend or family member or whomever, or a stranger. So I don't think, never mind, a stranger probably wouldn't take, I probably wouldn't take a half-eaten hamburger from a stranger. So that's not good. But so give that half to somebody you know. I'm just having this mental image, just walking into a McDonald's or something. Someone's like, here, my doctor says I'm not supposed to eat all of this. Be like, all right, you're a crazy person. No, thank you. But so anyway, but eat half, split the meal with somebody else. Only eat, half the slice of pizza or whatever, which is probably really hard. Pizza is one of my favorite foods, but so that's probably difficult for most people to do. But anyways, all joking aside, just encourage them to make smaller changes, more obtainable changes. Another book that I like too, it's called, so a book I like to recommend to patients is Food Rules. It's by Michael Pollan, and this guy has a whole bunch of, let's just go to his website. He has a ton of books and resources. He's done some stuff on Netflix. He's done some stuff on some different TV shows, etc. But this is it's kind of a guide to eating, very small, easy to read, quick read. And so if a patient if they're looking for a book, or if you want them, because a lot of patients are motivated and they're excited and trying to, so this is one, and it's not like he's not my uncle or anything. I'm not related to this guy. I don't get any money, but I'm not sponsored by Michael Pollan. It's just a book that I like. So, and I think and he has some podcasts too, but anyway, so you guys can hit him up, DM him. Look, he's on Twitter, slide into his DM. No, I'm kidding. I don't know. Don't tell him that I told you to do that. No, but so he's a great resource. Seems like a nice guy, I guess. But that's another book too that I recommend to patients, and my wife does as well. And he has, like I said, has some pretty simple, straightforward stuff. For testing purposes, none of this is on the test. This is just all FYI, by the way, guys. I'm just trying to expand your horizons. So, and then there's also this great table when it goes to lifestyle modifications, again, from Up to Date. Shout out to Up to Date, right? And you guys can read through this, but it's basically what I said, eat less, move more, stop smoking tobacco. Well, it doesn't say anything about tobacco, but stop smoking tobacco. And then moderate consumption of alcohol is another one. So, and then just one quick note about physical activity, and I try not to get too preachy to you guys, but with your patients, encourage them to try to fit physical activity and when they can. So they don't necessarily have to buy a gym membership. They don't necessarily have to go get new clothes and shoes, etc. To because again, depending on the socioeconomic status of your patient, may not be obtainable. But so one thing they can do is maybe if they take the stairs instead of the elevator, maybe park a little bit farther when they're at the grocery store, so they have to walk a little bit more to get into the grocery store. Things like that, where there's a book that I read on, I think it's called The Black Swan. It's not related to the movie. One of the scenes that I was reading in the movie. It's Black Swan. It's by Nassim Taleb. But anyways, and so he does a lot of great stuff about economics, and it's not really. But anyways, he was making the observation of how he saw people in New York City that were taking an elevator up 50 flights, 50-story building to go get on the Stairmaster at a gym, and then they were on the stair machine, where he was like, wait, you could have walked upstairs if you wanted to walk upstairs. But so anyways, and I'm usually not that snotty with patients, and don't make them cry or anything, but just maybe encourage them again to take the stairs in the building. Like the PA building has a couple floors, just use the stairs instead of taking the elevator, for example, if you can. So that's all the FYI stuff. This is not FYI stuff, right? This is the stuff I want you guys to learn. This is the second line treatment, again, according to guidelines. And this is the drugs, pharmacological interventions. We have drugs. Okay, I won't sing for you guys. Categorization, again, important. Look at them. You'll notice here there's diuretics, which is an umbrella categorization, which I want you guys to know. But then under that, I want you guys also know and be able to pick out there's loop diuretics, potassium sparing diuretics, etc. So know those. Definitely know those. And same thing with everything else. I mentioned the vasodilators too. Well, you'll see vasodilation come up in a lot of different modules or whatever. It has some benefits. But look at the vasodilators and then look at those categorizations. So let's jump into it. So this is based on the most current guidelines, but so you typically start with thiazide type diuretics. Okay, but I'm gonna jump here to this other presentation that I'm going to be posting and that you guys will have available. This is choice of drug therapy in primary, which is essential hypertension. It's a pharmacotherapy approach. This, again, you guys will have access to this, but I like this slide better as far as, so major options, thiazide type diuretics, ACEs and ARBs, angiotensin conversion enzyme, and we'll talk about those, calcium channel blockers. Those are your three main first options. Beta blockers historically were used more initially, but now they have more niche use, or the more current guidelines don't recommend them as much as first line as with the other ones. But anyway, so I just wanted to show you that because I like that slide better than the other one. The other one's not wrong. I feel students in the past have had problems with it, and that's probably the reason I created this other presentation. And then this is stuff too. I believe you'll be getting more in ICM. So, you know, just read through this slide, and we'll get to the different categories later. And then to combination, I know it was quick earlier when I showed you the algorithm, but there were some combinations there. So you can definitely do some of these drugs in combination with each other. First off, we'll start with the diuretics. So diuretics, what do? They cause diuresis, right? So they basically, what is diuresis? It's, long story short, it's basically fluid loss, right? So they essentially cause you to micturate, or in layman's terms, to pee out fluids, right? So that you go to the bathroom and basically get rid of it. So that is beneficial because of preload and afterload. So they help decrease preload and reduce afterload. So overall dropping blood pressure, right? Of these, the thiazide and thiazide-related diuretics are most often used because they also cause some vasodilation in addition to the diuretic effects. And then just real quick, jumping back to this other slide, they also are effective, well-tolerated, inexpensive. So they all are generic. They've been around for a long time. They're usually well-tolerated, etc. So a lot of good reasons to use these. Here are the thiazide-related compounds, so definitely look at those. And then just jumping back real quick, so thiazide and thiazide-like diuretics, just please keep those straight. But the thiazide one is hydrochlorothiazide, so you'll see this abbreviated HCTZ. So if you see that, I won't only put HCTZ on tests, but I try to spell it out and be mindful of that. But definitely something you see, I mean, when you're writing prescriptions or looking at charts, etc., you will see that abbreviation for that. And then as far as the popularity here in the U.S., physicians typically stick with the HCTZ and stay away from the thiazide related. But then in Europe and other countries, these are actually more popular, and there's maybe some lower side effects, etc. So you're starting to see more of the thiazide related compounds being prescribed here in the U.S. But anyways, just wanted to make a quick note about that. Make sure you guys know the abbreviation, and you'll probably see it, on a lot of your rotations, HCTZ being prescribed, the hydrochlorothiazide. So the loop diuretics can be used as an alternative. They're a lot more powerful as far as their diuretic effects. So they're usually used for other things like maybe heart failure, or if someone has really bad edema, or you're trying to get rid of fluid in some other ways. And there's just an example of that one there. But there's, that's typically not first line just for hypertension by itself. So if a person just has hypertension, you typically don't jump to the loops first, unless you have a really good rationale. And the same thing with potassium sparing diuretics. These probably aren't first line and usually not monotherapy, but they do. One of the advantages of, and it's in their name, is they do help prevent the loss of potassium. So you don't have to worry about hypokalemia, which you have to worry about with these other diuretics. So the use there, why we all came out today, no, hypertension. And then I mentioned before, they can be used as monotherapy, which means by themselves, or in combination with other drugs. And some of those are available commercially, so they'll make things with, an ACE inhibitor / HCTZ, right? Adverse effects. So definitely want you to pay attention to these. Lots of implications here. Unfortunately, these can be common, and again, testable on your boards, out in practice. Please, please, please put a star on this slide. So, and make sure you keep these straight as far as what they do to which lab values, let's say, right? So hyponatremia, hypokalemia, except for the potassium sparing, because they, I mentioned before, they spare the potassium. Anyway, so yeah, just look through those, make sure you know how they affect the labs, and because definitely something, if they're on higher doses or if they're on it longer term, you're gonna have to think about the implications. So, I mean, what happens with hyponatremia and what happens with hypokalemia, and again, longer term implications of those. So read through all of those. And the sexual dysfunction is not as common, but it is something that patients will complain about, and definitely you get patients don't want to take it if they're having sexual dysfunction. So that's just one I hear about a lot in the pharmacy, people complaining about. But anyways, and then, definitely if they had type 2 diabetes, hyperglycemia, that's a concern. If they already have high cholesterol, hyperlipidemia, right? If they have gout, hyperuricemia, those are things to think about. And then metabolic alkalosis, as far as toxicity is concerned, again, spending some time on this, I'm just so to kind of hopefully hit the point home, so to speak, and that you definitely need to pay attention to adverse effects. Contraindication. So I mentioned this before, but these actually should not be used in patients with a sulfonamide hypersensitivity. And this is one where, again, lay public will say they have a sulfur allergy, but it's really sulfonamide hypersensitivity. So we talked about antibiotics already. There's certain antibiotics that's an issue with. And so if a person has a true type 1 hypersensitivity to a sulfonamide, textbook medicine says, or textbook answer is that it is contraindicated with these diuretics because of their chemical structure. However, there's been new evidence shown that it's more of a theoretical risk than an actual risk, and so that it's not as dangerous as it was once thought to be. So just know, out in practice, you may see practitioners doing that and be feeling comfortable with it, and etc. Depends on the severity of the sulfonamide hypersensitivity as well. But for your boards and for testing purposes, I'd hate for you guys to miss something. And just so textbook answer is that there is a potential cross sensitivity, or cross hypersensitivity rather. If a person has a true documented, type 1 hypersensitivity, then it is a concern. So, and just a real quick side note too, with my course, I try to give you guys a mix of textbook or academic medicine, but then also of what is practiced, and then also too, I try to make sure you guys are up to date with new information and stuff. And so one analogy I like, and I don't think any of the students like it, but I'm going to keep saying it anyways, is it's like Roman, you can think of it as Roman medicine versus Greek medicine. And so this is nothing really historically accurate or anything. I just like the analogy. But it's the idea of like the Romans were out there building roads, fighting wars, they were soldiers, they had their armor, etc. Where the Greeks were wearing robes, interested in philosophy. And again, these are big stereotypes, and so any history majors out there are probably rolling their eyes. But anyways, I like to think of it like that because it's like the Greek, or it's like the academic medicine. It's more of a philosophical kind of best practices, what should be done. And the Roman is sort of like the real world medicine, what you see in the clinics, just what, like boots on the ground, what they're doing. So to kind of to flesh out this this analogy, bear with me, or you've already fast forwarded past this point, whatever, is that academic medicine, Greek, so to speak, is a sulfonamide hypersensitivity, but then it seems like kind of the Roman side of boots on the ground or out in practice, maybe more of a theoretical concern and not a real world concern. So anyway, so the reason I mentioned that, because sometimes I'll just say, like, Roman and Greek, and if I don't give the background, you won't know what I'm talking about. So anyways, furosemide. So this is a big popular loop diuretic. It is a very potent diuretic. You'll notice that's part of its first box warning. This is the generic of, and the brand name is called Lasix. Again, just popularly called that. Don't worry about it for testing purposes. But you'll notice the box warning on here. Definitely read through that. But fluid electrolyte loss. Definitely put a star by that. You always do, because it is so potent. It can lead to dehydration pretty easily too. But anyway, so please note that. And this is something that you typically just give, and we'll see inpatient. Occasionally, it is given outpatient, but it's typically not. It's used outpatient once you have established the appropriate dose for that patient. So it's not something someone comes to your clinic outpatient and you're like, yeah, all right, here's some furosemide, like hopefully this works out, like here's a couple weeks worth of furosemide, like good luck. It's like, no, you don't. It's dangerous and cause dehydration, fluid electrolyte loss. It can be very detrimental, cause hospitalization and stuff. So typically in the hospital they'll start this and then maybe keep them on it outpatient. But anyways, make sure you guys pay attention to the box warning. Mechanism of action. So read through all this, but take home point, it is a loop diuretic because it works via the loop of Henle. So here's the loop of Henle. You guys will be getting this probably in pathophysiology, but I definitely know the mechanism of action from my course. And take home point, again, for mechanism of action is it is a diuretic, which is also going to help you with classification, and that it works via the loop of Henle, and therefore it is a loop diuretic. And I put this loops lose because you'll hear that sometimes in practice, and or for studying mnemonics, etc. But just know that they can cause hypocalcemia, for example. So and so they lose sodium, chloride, magnesium, calcium. It's all right there. But so you may hear that or may see that, and then that will help you. Will hopefully help you remember the things you need to be worried about when a person is prescribed furosemide. Spironolactone. So this is a potassium-sparing diuretic, antihypertensive. We will also see it too in the endocrine module because it also has some. It's also considered an aldosterone receptor antagonist. So we will see that again later. But note on the box warning here, there have been some animal toxicities, and so this is one that's typically not first line. Again, you have to have a good reason. You see it. It's prescribed. It's not like something that's just dusty on the shelves in the pharmacy or whatever. But then note, avoid unnecessary use of this drug. That's that's language from the box warning. That's language from the FDA that just don't, again, like the analogy I gave, someone comes to your clinic outpatient and you're like, oh, here's some spironolactone for a month, just come back and see me, like hopefully this works out. Again, not something that you want to jump off with or start with. Guideline recommendations, again, I just put these in here more for ICM. As far as testing purposes for me, definitely know the box warning, but don't stress here about memorizing these. Again, for mine, the take-home point here is that these are not initial treatment drugs, right, for hypertension. But you'll notice here for heart failure, maybe they're used more and more, maybe more of a rationale for them being used. But since we're in the hypertension lecture, not first line for hypertension. Mechanism of action. I mentioned aldosterone earlier, right? So it competes with aldosterone for receptor sites in the distal renal tubes. And then this increases sodium chloride and water excretion while actually conserving the potassium. So therefore it is potassium sparing. It spares the potassium, and also hydrogen ions. And then it also, again, related more to endocrine module, but it also blocks the effect of aldosterone on arterial smooth muscles. But so yeah, take home point, it is a diuretic, and then you do not have to worry about hypokalemia, right? You don't have to worry. It's a potential advantage, and sometimes part of the rationale is, so that makes it a little bit different. But basically, distal renal tubules, where it has its effect, and then causes diuresis, right? Diuretic. Hydrochlorothiazide. So this is the one that I said is very popular, especially here in the U.S. It is the thiazide, right? And that comes from it. So classifications, make sure you know that. Again, works in the distal tubule. But then this one, it has effect on sodium, water, and then potassium anhydride as well. So it's losing all of that stuff, which is great when you're trying to lose fluid and you're trying to, maybe reduce your blood pressure, etc. But then again, what's the implication for adverse effects? We talked about your lab values and stuff, right? So you may have hyponatremia, hypokalemia, and those, again, may be something that you want to monitor while the patient's taking this medication. Chlorthalidone, like I said, more popular in other countries, but I don't know, maybe it will become more popular. I don't know. I mean, you guys have probably a long practice ahead of you guys, but maybe more popular. So read through the mechanism of action here. This works in a slightly different place of the ascending loop of Henle, but it's not a loop diuretic. It is a thiazide-like diuretic. So students in the past sometimes have kind of crossed their wires, so to speak, but for categorization purposes, don't get those mixed up. And affects sodium and chloride. So again, helps the body get rid of water. Take home point, right? Diuretic, diuresis. Indapamide, another one that you see a little bit, maybe if you guys end up, I don't know, practicing in Europe, you never know. Think big, my students. No, yeah, you never. But and the reason I mention that too is because this is what the guidelines and then like up to date say. It's not like I've been there practicing or anything. But anyways, so slightly different area, but basically distal tubule, the nephron, and then you have to be concerned about the electrolytes, etc. But take home point, it's a diuretic, increases diuresis, right? So increase excretion of water. Metolazone, another one, thiazide-like. So keep categories straight on this one. Distal tubule as well, and so you kind of notice a pattern here. And I'm not really going to grill you on the very, very kind of nitty-gritty. Very specifics and stuff. I believe you'll be seeing some of it in pathophysiology, so definitely pay attention to what you're taught there. But as far as the pharmacology goes, or my exam goes, I want you guys to have a general understanding. Definitely know if it's a diuretic or not, and then definitely know too, is it thiazide-like, etc. Next, we have the patholytics. And it's not related to sympathy or whatever, it's because it works on the sympathetic system. You guys remember that, hopefully from bio or whatever. And under here we have the beta receptor antagonists, which is also commonly referred to as beta blockers. Alpha-1 receptor antagonists, you also hear alpha-1 blockers. And then alpha-2 receptor agonist. So, and those are usually just referred to as alpha-2 agonists, right? They don't say blockers for there, but because those are an agonist, they're not an antagonist, right? So again, make sure you guys are keeping your category straight on there. Great mechanism of action as far as studying and learning this. It's the category names. This is nice. I always appreciated this as a pharmacy student. What do beta blockers do? They block beta receptors. So, and what effect does that have? I have all these things here. You notice a lot of different effects. Some desirable, some undesirable, so they relate to their adverse effects. Some beta blockers are more specific than others. They're more targeted beta blockade, so to speak. But overall, you notice here, and definitely with the blood pressure, why these are prescribed or can be prescribed for hypertension. Historically, they were used more first line for hypertension, and now for a number of different reasons, some safe alternatives, some other medications have come out. Refer back to that other slide I showed you that they are typically not first line. They're still in the mix and you still see them a lot. They're used maybe more for some of the other things, but I'm talking about hypertension here. And these, again, you see an inpatient, outpatient, see them all over the place. Use. So here is some of the rationale behind why. See, I don't just make this stuff up, right, guys? No. So this is some of the rationale of why these should not be first line. So I'll let you guys read through this. But this is from the American Society of Hypertension and the International Society of Hypertension. So they came together, both locally and internationally. They came together again. No, but Again, especially too with geriatric patients. So you notice that. So note that, you know, you've hopefully by now kind of get the idea of some of the things that I like to test about, or some of the things I want to make sure you guys know for your boards, and for practice. But definitely anytime something can't be used in a pediatric or geriatric patient, make sure you pay attention to that and study that. But then just and read through this whole slide because it has some compelling reasons too. Note too that it is maybe not a great choice or first line for a person who has diabetes, which you guys will probably be learning in ICM. You know, they kind of go hand in hand. I'm not going to say everybody with diabetes has hypertension or vice versa, but a lot of times there are comorbidities, as they say, right? And so that is, again, another part of that. But this is some good stuff. The other reason I made that kind of a mention of that is because sometimes with older practitioners, not trying to pick on anybody old, or I'm not an ageist or anything. I love old people. No, sometimes with older practitioners, you will maybe see more of this being used and prescribed, but you know, just know that you have to have a good reason, and there should be rationale for it. But anyways, here are some related beta blockers, but then also related to everything else. So when I was saying with rationale, that if you need to have a specific rationale, here are some rationales. So from Up to Date, these are considerations for individualizing antihypertensive therapy. I like this table a lot, and I'd like you guys to pay attention to it and look at it. Definitely squint at it, read through it, read the fine print. Look at this. This is going to help you with ICM. It will also help you with pharmacology and doing well in the pharmacology exam. And part of that is because on these board questions, you'll have someone who has, they'll describe a patient who has depression, right? And also has hypertension, because that is something that can happen. So which drugs may have an adverse effect on comorbid conditions? So if a person has depression, then maybe a beta blocker isn't a great first line choice for them. Or even second line, maybe, if you can avoid it, because it could maybe make their depression worse. So I want you guys to start being able to make those connections. And you might say, well, depression is from the psych module. So I'm gonna get on my soapbox here again. Sorry for ranting, but so the module learning is great for getting a lot of information covered in a short amount of time. But then I feel like one of the weaknesses of it is that and this happened to me as a student too. So I was on the module. I had these modules and had it sometimes doesn't do a good job of making the connections for the students. And so that was something I struggled with as a pharmacy student. And I know in medical school, I mean, this is something that's not unique to me or my experience, but so I try to remember that, be mindful of it, and make those connections for you guys. So that's the part of the reason I like this too, because this is going to be relevant maybe in the psych module, and then because I mean at the end of it in your board exam, and then as a practitioner, it's not like, you know, cardiology module and then this is, oh, you only have to worry about these drugs, because I mean patients, even if you work at a specialty clinic or whatever, patients have medications from you know, maybe other practitioners, or they have other comorbidities and stuff. So maybe they have osteoporosis. And so what implications are there? So anyway, so yeah, there's compelling indications. These are reasons why maybe you should start it. Likely to have a favorable effect on symptoms. So that's maybe good. Contraindications, definitely want to put a star by that. And you want to, you know, remember, well, put a star by the whole table. I don't want to say, but I mean, definitely make sure you pay attention to the contraindications. And then the adverse effects on comorbid conditions. Again, a lot of good stuff on this table. I put it in with the beta blockers just because it's related to the beta blockers, but this is good. You'll notice there's ACE inhibitors, there's ARBs, there's everything on here. So this is good for the whole lecture, for studying all around. Adverse effects. So I spent a little time with the depression. Notice central nervous system and specifically depression, right? So these are the beta blockers we're still talking about, right? So again, what are the implications? Maybe not a great choice for a person who has depression or anxiety, maybe, I don't know. Increased serum lipids, so there's cholesterol implications there. Hyperkalemia, which is interesting, but exacerbate asthma. So because there, and we'll talk about this more in the pulmonology module, but there's beta receptors all over your body. Well, there's some in the lungs. And so by blocking these beta receptors in the lungs, you can actually cause problems breathing. And so it actually may make it worse. And go ahead and add COPD there too. So beta blockers are typically not first-line treatment in a patient who has asthma or COPD. Let's see if it says it on here. Okay, it doesn't have it here. At least I don't see it quickly. But yeah, so exacerbate asthma, COPD, cardiac disturbances, and then sexual dysfunction. Propranolol. So this is a non-selective, meaning there are some beta blockers that have some selectivity as far as which beta receptors they hit. So that's what that means, non-selective. Box warning, pay attention to that. You'll notice too, this is kind of related to those cardiac disturbances I talked about, but this is specifically a box warning for this medication. Continued box warning. So just, again, please read through this. Don't stress about memorizing all this. Take home point, cardiac ischemia after abrupt DC, or abrupt discontinuation. Mechanism of action, it's a beta blocker, right? It's non-selective. I put the class of antiarrhythmic here because we're going to have an antiarrhythmic lecture that you guys will get to go through. And so these will pop up again. But so for hypertension, you don't have to worry about the antiarrhythmic class. However, you will have to worry about it for the antiarrhythmic lecture and section. And so I put it here just, again, hopefully kind of connecting the dots, so to speak. But this one, again, it's non-selective, so it hits beta 1 and beta 2 blockade, which has all these different effects, which, again, some are good, some are bad, or some are desirable rather, and some are undesirable. So you can read through the rest of that. Metoprolol. So this is selective. It's selective for the beta 1 receptor, and its half-life is not, let me change it real quick. Okay, my computer's messing up, it's being annoying. So anyways, it's beta 1 selective, half-life, so this is 1/2, so that's the abbreviation for half-life, 3 to 4 hours. And then they do make extended release products, which don't worry about memorizing the half-life. That's just kind of FYI for you guys for now. Atenolol, this is also selective, beta 1. Half-life there, 6 to 9 hours. This one can be better tolerated because it is selective for asthmatic patients. But again, just as a class in general, the beta blockers are not first line for people who have asthma or COPD. So it's relatively better tolerated than propranolol. But then again, there's other things that don't hit the beta receptors at all. So there still has been some evidence and some research done in that atenolol, or these selective beta blockers, initially they thought, oh, it's selective, so it's gonna be better, but then kind of history has shown, or with research, etc., the selective ones aren't, again, first line for if someone has hypertension with asthma, COPD. One advantage, though, it does have fewer CNS-related adverse effects, and it's related to being less lipid soluble. And so again, if a person with depression had to be on it, a beta blocker, maybe then atenolol could be a rationale for picking that one over some of the other ones. Next, we have the alpha-2 blockers, methyldopa and clonidine. Mechanisms of action, again, very nice for classification and mechanisms of action. Take-home point that they are alpha-2 blockers, right? So you can read through that. Please note these two as well, these two uses. So it's not used a lot, but it has its niche uses. So it's not typically drug of choice for the elderly population. So please note that. And it typically is preferred and can be used during pregnancy. So also want you to note that. Because if you'll remember earlier, we had that table from Up to Date that has, there's some of the other antihypertensive like the ACEs and the ARBs that should not be used and are contraindicated in pregnancy. So this is one that you'll see sometimes being used for hypertension during pregnancy. Adverse effects, read through those. You notice hypotension's there. That is something that you should have in the back of your mind too. I haven't necessarily mentioned it till up until this point, but have that in the back of your mind with all these antihypertensives. It's kind of like with the coagulation medications and bleeding. Be thinking about that with all these. It is something that can happen. And then these last three here are the rare but serious adverse effects. So these are more common up here, and then down here, rare but serious. Clonidine, again, has this effect on the alpha receptor, right? So that's the take-home point. This is its effect, so it does have some antihypertensive properties, right? And here's a more elegant, for lack of a better, here's a more elegant mechanism of action. Just read through that and okay, I accidentally had the pause button on, so I don't know how far I need to go back. Okay, so my apologies if this is repetitive. I want to make sure I hit all the highlights for clonidine, because I was rambling about clonidine and then I saw the big pause warning. So anyways, mechanism of action, take-home point, it's an alpha blocker, right? Has these different things. I listed a lot more here. Read through the mechanism of action, just know because it does have a lot of different uses. So read through those, but take-home point for that. In its uses, transdermal is used so they make a patch that can be used to help with compliance, but not that popular. It can also help with pain, so read through that. Kind of a niche use there. Extended release, FDA approved for ADHD. It is expensive, so usually they'll go with the cheaper one, the clonidine, if a patient can't afford that. But by itself or an adjunct therapy with some of the other stimulants, which we'll talk about in the psych module. Uses, lots of uses here. Look at all of those. I definitely associate this with my time working in the psych hospital because of the a lot of different uses that we prescribed at a ton there. So heroin nicotine withdrawal, ethanol dependence, impulse control disorder, ADHD, clozapine is an antipsychotic, induced celeria, which is drooling. Adverse effects. So these are the common ones. And first one on there is dry mouth, which this is medically known as xerostomia. And it's very severe. So it's not like, oh, I'm dry mouth and I want to drink water. It is super like bone dry, very uncomfortable. Patients hate it, and it causes people to stop taking the medication, etc. Sedation causes sedation, which is sometimes why it's prescribed. It's one of those adverse effects. And so the sedation sometimes was desirable in the psych hospital, for example. And then hypotension, so postural hypotension, something to think about there. And it can be profound as far as causing dizziness and stuff. And then you definitely need to taper off of high dose therapy because you can have rebound hypertensive crisis if you just abruptly discontinue this patient when they're on high dose. So please note that as well. Next, we have the alpha-1 receptor antagonist. These all end in Osen, right? Zosin, prazosin, doxazosin, and terazosin. Oh, they all actually end in azosin. So that would help you guys remember the category and which ones fall into that. Mechanism of action, take-home point. They are alpha-1 blockers, right? But go ahead and read through the rest of that. So they are used for hypertension, which is why we're talking about them now. And then later we'll talk about them in the GU module because they also are beneficial in BPH. So that's, and for you guys don't know, it's basically an enlarged prostate. And again, we'll talk about that a lot more later on. Adverse effects, hypotension again. So think about that. Definitely note that. Again, making that generalization too for all of these. This is something that can happen more with the first dose. And so you have to maybe start, there is a rationale with BPH as well, starting at a lower dose. And then also dosing it at the evening, so QPM at night or at bedtime. QHS is a bedtime abbreviation. And so that if they have the dizziness or they have the hypotension, it's when they're asleep. So you notice dizziness too is a common adverse effects. Also some sexual dysfunction too. And then just note, this is one of those niche things, but they shouldn't, it's contraindicated if they're going to be undergoing cataract surgery. The drug interactions there, that's noted just because you have to be mindful of this medication when you're prescribing with other drugs that can cause hypotension, because then they'll work together and it'll have more of an issue with hypotension. So I'm going to stop there, and I'll continue here with the vasodilators in part 2. So as always, feel free to email me if you have any questions. Thank you guys for your time and attention. I'll talk to y'all later.